they've already distinguished that fomite transmission or transmission from surface to surface is lower than a lot of other viruses. So there's something different about this virus, and it could be the amount that it takes to become infectious. There's something different about this virus, especially when it comes to the elderly and people with underlying conditions. And one of the things that we would have expected to see by now is we are expecting to see some additional research by the CDC based on what happened overseas, based on what happened early on over on the west coast of the country when we first had our first couple of cases. We would expect to see more research at this point. So we're waiting with that. We've seen trickles out of the degree of immunity that you have, how long it lasts. We're not sure on those yet, but we are starting to see studies that are coming from Europe saying that the antibodies start to lessen over time, which is not surprising to any of us. So it may not be a one and done virus, right? That's what everybody wants, is you get infected once and you are immune for life. And as is the case with a lot of coronaviruses, that's your immunity starts to wane. So we are really waiting for that research, but it could be a possibility that just like you get your annual flu shot every year, that you may be getting an annual COVID shot every year once we get a vaccine for this virus. So it could be two things. It could be a lifetime immunity, but we don't think that's overly probable. Or it could be once a year, once every other year, depending on how long your immunity lasts. I am excited that maybe our flu shot rates will go up this year. That would be exciting. We've not always had great flu shot vaccination rates across the country, really. And New Hampshire is about the same as the rest of the country, but I think people are going to be much more cognizant this year that to get that annual flu shot. And I think that you may see COVID going on, not this year, unfortunately, maybe the following year. So early on in the pandemic, a couple of things that really kind of came to light. A lot of our emergency plans in this state and every other state across the country rely on our federal partners to do a couple things for us. Strategic National Stockpile being one. And everything that we do in New Hampshire and around emergency management relies on this Strategic National Stockpile. And people didn't know exactly where it was or what was in it, but we were always told to rely on that. So some of the delay early on, and you saw this, is that there was this scramble to get PPE and testing supplies and all of those things, is that every state put in requests to the Strategic National Stockpile all at the same time. So what they did have certainly was not sufficient to supply all states with everything they needed. And it became very, very evident early on that we needed to become much more self-reliant. And this is where our team with the governor and myself and the Department of Safety and Homeland Security and our private partners like DECA and Dean Kamen, which we can't say enough about Dean and the help that he's given us over the last couple of months, have come together and said, how do we make New Hampshire self-reliant? How do we bring our PPE in? How do we get testing capability? How do we get the skill sets that we need? And very quickly, as a team, we came up with a plan to do this. And with the governor's push and flexibility to use the money how he used, you started to see planes coming in. I can't say enough about that team. Perry Plummer was there at the time, the governor, myself, General Conway, and General Michaelitis, getting those planes into land. And very, very quickly, we built the cash that allowed us to be self-reliant in PPE. And that was a distinction that we had that was very different than a lot of other states. It's something that we did really, really tremendous on. Right now, our push is to become more self-reliant in testing. We still rely on our commercial partners very much to do some of our testing. And for the last several months, we have been circling the wagons around how do we bring more in-house testing, because it allows us to do two things. It allows us to control the quality, i.e. turnaround times, false positives, inconclusives, and it allows us to control the cost. And right now what we're seeing is that our commercial partners, Quest, LabCorp, all of those big labs who have been great partners, our turnaround times are being impacted by what's going on in the rest of the country. So our turnaround times 3 weeks ago from Quest and LabCorp were 3 days. They are now up to 8 days, just 3 weeks later because of what's happening in the country. So what we learned very quickly is that we need to become a more self-reliant state. So you'll see that some of our grant money that we put in for additional analyzers for our public health lab. We're leveraging our partners with Dartmouth Hitchcock. We have different analyzers and equipment at different hospitals. We will be moving to a hospital-based community testing system in the next couple of weeks. We're averaging about 2,500 tests a day at this point, a positivity rate of under 2%. We're doing really, really well. And at the same time, we are watching what's going on everything south of us, because as we've discussed many, many times, is New York City, Boston, all of those, even Providence, Hartford, Connecticut, they're all kind of our canary in the coal mine, where we're going to see this rates start going up there before they get to New Hampshire, and we are preparing. We've already set our PAR levels for September, October for the surge. We know what's our trigger point for ordering. We are all over PPE, but even right now, it is difficult to get PPE because of what's happening in the rest of the country. We're lucky that I think we have our 8th plane landing today or tomorrow, which we have isolation gowns on, which very, very important. We were low on those right now. Our critical area is gloves. We're having a hard time ordering gloves, but we're trying to hit every manufacturer we can find to get those. So really planning for our next surge in September, October. We hope it doesn't come. We actually hope that the states that are currently peaking are behind us. That's my goal. And that's my hope, is that we had our peak, and these southern states are peaking now and they're behind us and we're through it and we're never going to see it again. That's wishful thinking, I know that. But that is what I'm hoping for. But in reality, we do think that we are going to see, especially when colleges and schools come back, a big spike and a jump in our numbers in September, October. So what else did we learn? Complex systems. So this is something that, for someone with an operations background, I felt like I was very, very prepared to start putting together complex systems to do things like testing systems statewide, the difference between PCR systems, antibody systems, leveraging our relationships. But then, everything, you look at the impact. When we first started preparing for COVID, our complete focus was on alternate care sites, because what we were hearing from our partner states was that they were running out of hospital beds, right? So we very, very quickly stood up thousands of hospital beds, literally thousands of hospital beds in the run of 2 or 3 weeks. National Guard helped. We had logistics people on the ground. We supplied them. There's a ton of media coverage of both the governor and I walking through these huge sites with thousands of beds. And lo and behold, in New Hampshire, and not overly shocking, we are the 3rd oldest state in the country, right? So the main driver of our experience in this pandemic was in long-term care. And so we quickly pivoted. We left our ACSs, our alternative care sites, and 3 still stand today. We pivoted away from that into long-term care testing. And we found out yesterday we are one of 7 states in this country that are requiring long-term care surveillance testing. So that means that all the staff in every nursing home in the state gets tested every 7 to 10 days, and 10% of the residents in every facility gets tested every 10 days. And if there is even a single positive, we go through and we test everybody. We are one of 7 states that are doing that. You will see that our numbers have come down dramatically. Some of that is our lower community transmission. Some of that is our very aggressive approach to testing and treating and long-term care right from the get-go. So I think every state's a little different in how they experience this pandemic. And for sure, in our state, long-term care has been the most dramatically hit. And creating complex systems around testing nursing home residents, testing staff, having critical facilities that have critical staffing needs, and how do they get set up to get additional staffing, both from other healthcare partners, from people that were furloughed, from people out of state, and then people that DHHS worked with to do that. So there's been a lot of systems and different skill sets needed for sure, not just on setting up those systems, but reporting out the data that go along with it. As you've seen, if you've watched any of our press conferences, transparency is huge. It is a priority for both me and Governor Sununu. We spend a lot of time explaining, giving data, making sure, correcting data. Today was a correcting data kind of day at our press conference. And I hate doing that, but I know it's necessary, and I believe that we need to own it. And I know the governor feels the same way. You know, I've said this several times at press conferences. It's like we are building the plane as we fly it. The system never existed, so we are building the system as we are working within the system. So there are going to be errors and corrections that need to be made. So just the data system to stand up accurate reporting has been an extremely heavy lift for New Hampshire, but we did it, and we did it quickly. I mean, when you look at it, at not just our state, but state government in general, that typically takes several months to get anything this big done, maybe even several years at times, we stood it up in a matter of weeks. So very proud of my team. I'm very proud of our state government team, you know, not just HHS, you're talking employment security, you're talking Department of Safety. I mean, all of these different state agencies come together. When employment security was having their surge, we had admin assistants from HHS answering the phones for them. I'm pretty sure they had DOT staff answering the phones for them. It was really a kind of everybody come together and do what we had to do to make it work for our citizens. And a very proud moment for the last couple of months to watch everybody come together and work together. It's been very rewarding. So really, I think people became very skilled at not accepting your first no. And I say that because it's been something that I've said right before I even got to commissioner. You know, someone would come to me and say, you know, I asked to do this and they said I couldn't. And I said, and then what did you do? You know, you've got to push past the first no. And I've said it, when there's a million reasons to say no, you have to find the one reason to say yes. And I've said that 100 times in the last 3 months, that you need to find the one reason to say yes to everything. The one reason why someone needs to be tested, the one reason why you know, someone needs to get priority, the one reason why you need to find the reason why, because we're here to serve the citizens of the state. And if I imparted anything on my team over the last 6 months, it had to be part of that, right? Is that we have to find the reasons to say yes, and we really need to come from a place of servant leadership. We are here to serve our citizens, and we answer every call, we answer every email. If I've heard anything in the last 6 months, is they're like, I can't believe you're answering, you know, an email you sent me. I answer every email, I answer every phone call, and I expect the staff at DHHS to do the same. I believe we need to be accessible to the people we serve. So I'm gonna stop there for a second and open it up to questions.
Okay, very good. Thank you, Lori. So if you want to just type your question in the chat, I think that might be the most efficient. So if you go to the bottom of your screen and click on chat, you'll see, and you can type some questions there. I'll start with a question. How are we seeing related problems, drug overdoses, suicide, untreated medical conditions other than COVID, things like that? Are those kind of problems coming up?
So originally, the reports that we got was the first couple of months of COVID, we saw all of those levels sink very, very low. We saw the overall utilization of mental health services, doorway programs, SUD overdoses, elective medical procedures, less time-sensitive medical procedure, everything went down. And then what we have found over the last several months, well, it's the last 6 to 8 weeks, is everything started coming up again. You'll notice even our ER boarding crisis numbers, right? We were very lucky. You know, when I took in the commissioner's position, we were down around between 15 and 20 for ER boarding. And we maintained that, and we actually got to 0 a couple of times, and people just stopped seeking the mental health services in the ER. I think there was some fear in that because of COVID. So in the last 6 weeks, I think, 3 days ago, our ER boarding number was around 40. And no one, the reports that we're getting is people are finally more comfortable accessing care after several months of waiting. We heard when we started opening the hospitals to time-sensitive care and now non-time-sensitive procedures, what we heard from a lot of physicians and a lot of surgeons is that, the procedures that were non-time sensitive or time sensitive are turning into urgency and emergency surgeries because we've put them off for so long. So it was really important for us to move through that continuum fairly quickly so that people didn't get in a position to be needing an emergency surgery versus just a time sensitive surgery. Okay, let me look at the questions I have. Do I feel that mask wearing provides a benefit to the user and those around them? Absolutely. I will tell you, hands down, one of the best things we can do is use masks. There are many depictions on why this is, and it really is only to contain the droplets, right? That is, people look at cloth face coverings and they say, well, if cloth face coverings prevented you from getting the virus, we would wear those in healthcare. That is true. What it does is it prevents you from spraying droplets when you talk, when you sing, when you yell, sneeze, cough, any of those things. So it gives a level of protection to everybody else. So the expectation to people wearing cloth face masks and 6-foot social distancing would create a very low risk environment. And that's what we're trying to create. I wear my mask whenever I leave the house now. And we'll be doing anything except for outdoor activities. I am always in a mask, and I think it's really, really important that that we take very serious the mask wearing for New Hampshire. Do we have credible age-related fatality rates? Yes, we do. We have. I'm assuming, Bill Taylor, that you mean credible age-related fatality rates due to COVID. If you go to our DHHS dashboard, you will see on that dashboard that all of our case rates, our hospitalization rates, and our death rate is broken down by age range. So you will be able to find all of those there. You are going to see predominantly the vast majority of our deaths regarding COVID are for people over the age of 60, but we do have some under the age of 60. How are we handling contact tracing? We have never stopped doing contact tracing. It's probably one of the things that I would say that has led to us having the success that we've had. We have about 125 contact tracers for DHHS. That does not include the city of Manchester and the city of Nashua, both who have contact tracing teams. So when we get a report of a positive, we go back 48 hours from the time of testing and then forward, and we contact we take a very clear, detailed health history, disease history, and an investigation, and we go through everybody that would have a close contact with that positive person. So, and then we contact that close contact, and at this point we recommend that they get tested. So every single person that has a close contact to someone that's positive will be contacted by public health. One of the big obstacles that we've had is people not wanting to answer our calls. Believe it or not, in this day and age when we all have caller ID on our cell phones, and people see public health calling and they go, no, thank you, I'm all set. So we encourage everybody to pick up the phone for the public health so that we can really give them the information they need. So contact tracing, it really works to suppress the amount of community transmission we have. Any insights into how COVID will affect the health of our K through 12 kids and how we can minimize spread to adults? That is a really, really tough topic, and it's one that's going on right now with back to school and reopening of schools. I think across the board, they've seen that that kids don't have the same level of negative health effects as adults do, but they transmit the virus. We haven't seen evidence yet that says that they don't transmit the virus to both adults and even elderly adults. And one of the concerns have always been is, kids that go home to their grandparents' house after school and things like that and being able to transmit. So how can we minimize spread to adults? Same things, masking, 6-foot social distancing, staying away from any large gatherings, creating almost a family bubble. That's what anybody that knows me knows I'm from Canada. So I've gotten to watch COVID management in Canada as well as in the United States. And they created bubbles around families so that you interacted with one other family or your own family, and that was kind of your social interaction. They haven't had a case of COVID in my hometown or in Cape Breton Island for weeks because of some of these measures. So really staying away, what's really scary is super spreader events, right? That's always what we're trying to prevent is super spreader events. So think one person going to a wedding or a funeral or in a classroom that is symptomatic and spreads it to like all the people that are around them. That is our biggest fear, because when you look back globally at the spread of COVID, there are certain super spreader events that kind of changed the trajectory of this pandemic. Biogen was one of the ones just south of us in Boston that had people fly in from all over the country into Boston. A lot of people got affected, and then they flew back to their individual states, some here in New Hampshire, and then continued to go on with life. And that, in essence, took the virus to many different parts of our country. So really preventing those big super spreader events. And that is, some of the fear of the schools, and not just K through 12, even colleges, it's worrisome for colleges and dorm living and things like that coming on in September. So minimizing the spread to adults is masking, social distancing, and avoiding large events. Has the route of infection into nursing home has been identified? Well, I can tell you that there is no peer-reviewed research to tell you this, but what I can tell you is that even in facilities that have had no new admissions and no residents go out for any type of care, that there has been cases where staff and residents become infected. We can only imagine and we can only assume that because staff are part of our communities and our numbers of asymptomatic positive people is quite high, that we have asymptomatic staff that are bringing it into the facility unknowingly. We've been watching very carefully because there's been a lot of discussion about asymptomatic versus pre-symptomatic. Or just general symptomatic COVID. And what we have seen, and there is no rhyme nor reason for this, we don't know the science behind it. We've seen, 100-year-old nursing home residents that's COVID positive that never have a symptom and never have a negative effect from the virus. We've seen 60-year-olds that get put on ventilators within 48 hours of getting sick. We've seen plenty of pre-symptomatic people. They're asymptomatic at the time of testing, but develop symptoms over time. And then we've seen people that have never developed symptoms, but tested positive. So our assumption is that with the staff being part of the community and having high community transmission, especially back in April and May, that there was some transmission between staff and residents. And then it just is cyclical, right? Then one resident gets it and can transmit it to other residents or other staff members. And before you know it, you have multiple people that are testing positive. What is the turnaround time for COVID tests, and are there targets turnaround time? Yes, so I would say the longest I'd like it to be is 3 days. And our turnaround time varies right now. At the public health lab, it's about two days. At Dartmouth, it's less than a day. Quest, LabCorp and Quest is between 7 and 8 days. That is up from 3 days, which was about 3 weeks ago. 3 weeks ago, it was about 3 days. And then when a lot of the rest of the country kind of exploded, their turnaround time went from 3 days to 7 to 8 days. So our target is no more than 3 days. We have rapid testing in hospitals that you can, that really sick people can get tested on like a Cepheid device or an Avid ID device and get pretty quick testing. But for our regular surveillance testing, 3 days is what our goal is. What is your position on absentee ballot? I don't have a position on that at all. It's not healthcare related. If the governor's on, he can talk about that. I'm completely out of the loop when it comes to the election, besides the fact that my boss is running, and I very much appreciate that. But my role is on health and human services, and when our elections happen, to make sure that they can happen in a way that everybody that is both working there and showing up to vote can be as safe as possible. And that's been, it's not whether absentee ballots can happen or not, or more, they happen now, but to a higher degree or not. It really is about however the system chooses, which is up to our elected bodies and our Secretary of State and all of our communities. However we choose to do it, we need to make sure it's as safe as possible. That's my only involvement. I clearly heard you. I thought you said our positivity rate was 103%. No, our positivity rate is between 1 and 2%. It's been right around 2% for well over a month now, probably more like a couple of months. Well, it's been under 5% for the last couple of months. It's been under 3% for at least the last month. So our positivity rate is really, really good right now. That's exactly what we want to see. What expectations do you have regarding the expected surge later in the year and the mental health needs of the state? I expect similar to what we saw in our first surge, is that people are going to delay care until they cannot delay care anymore. And specifically for mental health, that is the difference between hospitalization and not. And it's unfortunate, and I'd rather see it not happen. People that get a little bit depressed and have, depressive disorder, and then need to self-isolate. They don't have access to their support systems. They don't have access to in-person counseling. You see that delay in treatment, and you know that it's going to result in a spike in mental health claims and mental health needs. And we're seeing that right now with our increasing numbers of ER visits for mental health. Do I think it's going to be long-term like that? No, I think that we're going to restabilize, and my wish would be for us to restabilize and go back into a system that met their needs like prior to COVID. But I think part of the issue is we're in a lull right now. And when we come out of that lull and we have another peak, people are going to go back into self-isolation, and then we're going to see more unmet needs. To be honest with you, when we look at telemedicine, and telemedicine through COVID has been one of the great things. Like telemedicine, the fact that we have stood up telemedicine in this state so quickly has been incredible. But one of the areas it just does not work is in mental health. You just cannot develop that therapeutic relationship with a patient sitting at a computer screen. So for our mental health system, I really want regular in-person visits to come back very quickly. If most deaths are over the age of 60, why shouldn't people say younger than 50 go back to work? Because we are one community, and community transmission doesn't discriminate on age. So if you think about this, and like the majority of people are back to work. I just want to put that out there. There's a lot of people back to work. We're seeing our unemployment rate tick down every single day. So a lot of people are going back to work. But when we just talked about nursing homes, right? The nursing assistant that's in a nursing home shops at the same grocery store as you, goes to the same Dunkin' Donuts as you, goes to the same doctor's office as you. And if that person comes in contact with it due to community transmission, he or she risks bringing it into the nursing homes. And what we're seeing across the country right now is that the states that are seeing their surge is also seeing a surge in nursing home outbreaks. So there is very, very realistically, it is tied to your rate of community transmission. So the more community transmission we have, the more likeliness that it's going to get into the nursing homes, and that is where the death rate is so high. With all the contact tracing you've done, do you have positive evidence of infections from non-symptomatic carriers? We do not have research-based, but what I can tell you is we have plenty of examples, and we hope to release this probably in the next 4 weeks, of the amount of non-symptomatic carriers. It's incredibly high. So I'm not saying it's over 50%, but it's definitely 20, 30%, maybe higher than that, of people that just had no idea that they were carrying COVID. So what's going to be interesting is when this is all over, to go back and look at the data. You know, one of the things public health tells me on a regular basis, they're used to having these short-term outbreaks where at the end of the outbreak, they go back and they evaluate all the data and they come up with their conclusions. This is more of a long-term sustained effort where we need to learn things as we go. So right now we are looking at the data from the last 6 months and say, what have we learned about COVID thus far to prepare us for the next surge that's coming in September, October, if it comes. So we have lots of examples of non-symptomatic carriers or asymptomatic positives. I don't have anything that's researched yet. I'm hoping the CDC is going to be able to come out with something soon. What percentage of our positives are asymptomatic? I don't have the number in front of me. I would say it's north of 25%, but that is a shot in the dark for the most part. I'm hoping to have those very real numbers out in the near future. So we know that it's less than 50%, but it's not a small percentage. The Japanese approach to managing COVID while avoiding lockdowns has gotten some attention in the Wall Street Journal and from other experts like Trump FDA Commissioner. Has New Hampshire considered implementing a PR campaign to avoid closed spaces, crowded spaces, close contact settings? I interact with many highly educated people who do not understand the risks. I think we have a current campaign underway right now of Don't Go Viral, which is the governor's campaign on masking up New Hampshire. And that is really to target the younger people that seem to like to congregate in large groups. And we've seen that in other states. We have, at every single press conference that we've had, I would say across the board, the governor, myself, and Dr. Chan have said over and over again to avoid closed spaces, close contacts, keep your 6 feet social distance, and wear a mask. There have been a variety of campaigns around this. In addition, we bring attention to it every single chance we get. I think New Hampshire has done okay at this, and some of it is just our demographic. We don't have kind of the bars that some of our southern states have, right? We don't have a lot of those crowded bar type venues. So that's good for New Hampshire right now. A lot of our restaurants are not set up that way. So I think that we've done a lot of messaging around this, and I'm not sure how people aren't getting that message, to be honest with you. We talk about it so much and so often. I don't know any other state that does twice a week press conferences, and that's going down, because we were doing 3 times a week for months and months and months. And every single press conference, I bet you we dedicated 20 minutes to those exact topics of masking up and being socially distanced. So in a lot of ways, you know, we can do any campaign we want, but people need to want to consume the information. The information's there if you want to consume it. It's on our social media page, it's on TV, it is on the radio, it is everywhere that we go and we talk. I know the governor spends a lot amount of his days he does live on MUR probably once or twice a week. He's on the radio a couple times a week. I'm doing a couple spots. Ben Chan does several spots. So I don't know how we can make it more visible to say, stay 6 feet apart and wear a mask and don't go to large group gatherings, because we've said it so much. Congrats on your effectiveness statewide. You must have been effective in getting people to follow your advice. New Hampshire folks are traditionally strongly self-reliant and independent. How do you think you have effectively pushed through the inevitable pushback to get the results you have? I think New Hampshire citizens have done a tremendous job. You know, we are self-reliant, and I think that has worked to our advantage, to be honest with you, is that we dug in and said, how can we fix this for New Hampshire? We can't rely on anybody else. We need to fix it. And I think that we did. And, you know, you watched people rally around communities, nursing homes. I mean, the outpouring of support to nursing homes was incredible. And, you know, I will tell you a story that I had conversations with other commissioners from other states and nursing home providers from other states. And they asked me, they said, how have you kept the messaging around nursing home illness and death positive? Like, we are not hearing in New Hampshire that the state is saying the nursing homes are doing anything wrong. There's no like big bad surveys coming in and sanctioning facilities. All of those things happened. I'm not saying they didn't happen, they did happen. But I truly believe that in order to be effective, everybody needs to partner together. And we partnered with our nursing home, and we partner with our hospitals, and we say, how can we fix this together? And I think that's how we have pushed through it, and really kind of circled the wagons to say we can do this. There was I don't know of one industry in New Hampshire right now, healthcare industry or group of providers that we have an adversarial relationship with right now. We just don't. We have worked with every single provider to say, how can we help you? How can we support you? Yes, nursing homes have been invariably affected much more. It is not their fault. This is how the pandemic played out. They did the right things. It's COVID. That's what it is. And one of the things that I've been very clear on is we do not point fingers or blame anybody. We're all in this together. What was your involvement in school plans for reopening? The Department of Public Health's involvement was very, very involved. So some of these more complex plans, like the school reopening plans, although I've read it and been involved in it, Dr. Chan has been the primary and on the forefront of plans like that for sure. He is the epidemiologist. He has a great brain when it comes to thinking through the potential risks for reopening and things like that. So although I've been involved, it's been Dr. Chan that's been the lead on that one. I've heard reports that the Swedish approach worked well. Do you think that's accurate? Some cited some CDC data for total deaths from all causes week on week that suggested that 2020 had fewer deaths than one of our recently bad flu years. I can't remember which year. Is it working out overall to be about as deadly as the flu, but different age related? For New Hampshire, no, it is not working out. The death rates are not the same as the flu. Even if you look at the death rates, when you look at the fatalities from influenza in nursing homes, and you look at fatalities from COVID in nursing homes, we are so far above that. I've never seen in one of our facilities that was like 120 beds to have 25 people die in 8 weeks. I've never seen that before. Not in all my long history of working in long-term care. And so our outbreaks tend to last about 8 to 12 weeks. I think our attack rate is going down. I think our which is good because we've put different things in place. We've put masking in place. We've put those types of things in place. So when it all shakes out, right, I guess the big question is that if we spend a good amount of our year at home, not commuting to work, not getting into car accidents, not having accidents overall, not engaging in other things that, you know, cause illness and disease and accidents, will our death rate be about the same? I have no idea. All I can speak to is that I do not believe it's what you're going to see is you're going to see lower rates of influenza, both at the end of the influenza season last season and probably at the beginning of influenza season this year, because the way you prevent the spread of influenza is the same way you prevent the spread of COVID. So you're naturally going to see less. I think what generally what your comparisons are probably going to be the 2017, 2018 flu seasons, and then this 18, 19, 20 COVID/flu season. So yet to be seen. Is the antibody test accurate enough to be worth taking? I think I had COVID in January. From all the reports that I get, yes, it is. So it is accurate enough, but the question, because you had it in January, I would be, I'm less confident than if you were asking me this in March, right? So what they're saying is that your antibody levels you start to fall off. I still think it would do good to get it if you're curious. Ultimately, it's not overly diagnostic for us because you don't have active infection. There's nothing we need to do with you, 6 months after maybe you've been impacted. We contact trace every single positive antibody test to find out, when do you think you were sick? Where do you think you may have contacted it? Who is your close contacts? We do all that, but when it comes to stopping the spread of COVID, we find the PCR test much more helpful in that realm. Is the COVID-19 testing accurate enough to really know if someone has it if they are asymptomatic? Yes, we are seeing quite a bit of asymptomatic positive testing. And although there are reports of false positives across the country right now, not 20 or 30%. So we are seeing both asymptomatic and pre-symptomatic. So we're seeing positive tests for people that have no symptoms at all, and then 4 days later they develop a cough. Yes, I do think it's accurate enough. There are different tests have different degrees of accuracy. Abbott ID right now, which is your quick 15-minute test, most useful when it's positive. If it's a negative test, we ask for a second swab to be sent to another lab. When someone tests positive, how long are they typically contagious? Usually about 7 days. So we ask people to isolate for about 7 days, and after your symptoms reside for 3 days after that. So no fever, no cough, no symptoms for 3 days, but from the onset of symptoms, about 7 to 10 days. So the other thing that you should know is that even a month after you've had symptoms of COVID, you can still test positive, because the PCR test is so sensitive that it picks up dead RNA, so non-viable virus RNA, and it'll come out positive even a month later, but it does not mean you are contagious. The Wall Street Journal says that Qatar has found between 50 and 95% of those who test positive have no symptoms. We're not that high. I don't believe we're that high. Unless we test all of our population, I don't know that we'll know that, but we're not seeing evidence of that. I am so happy to be here in New Hampshire. Me too. My brother-in-law is a manager at CVS in Maryland, which has and is a COVID hotbed. We're way ahead of Maryland in setting up remote learning and shutdown. I do think you do a great job of getting information out. Thank you very much. You are right that people need to want information they trust. Also have to trust the resource. Yes, they have to trust the source that they're consuming it from. I'm a new face on the scene. There's no preconceived notions about who I am, right? So between me and Ben Chan, even if you want to take the politics out of it, Dr. Chan and I are pretty neutral people. So we're hoping to garner that trust from our communities because there's no political partisanship here. We are healthcare professionals, right? That's one of the reasons that Governor Sununu appointed me, is because I've been a healthcare professional all my life. I've never, I'm a nurse by background. I've done long-term care. I've done mental health. So one of the great things, and the governor has been acknowledged for this nationally, is that he's letting healthcare professionals kind of run the response to this. He's a partner, he's part of our team and we're part of his team, but it's not just him talking. That's why he has Dr. Chan and I talking also. Do you see any spreading events associated with extended family social events in New Hampshire? So we haven't identified a date. So people often ask, can you identify cookouts on Memorial Day or cookouts on 4th of July? No, we haven't identified those, but we have identified extended family spread. So one person testing positive and maybe having a cookout or an extended family over for a visit, and it's usually close contacts of someone that's positive on where it's spreading. We should be coming out with more data around this in the next week or so, but what we're seeing is a lot of our data is around close contacts, family, household members, extended family, things like that. Do you anticipate a vaccine and will be available to New Hampshire residents? I do anticipate a vaccine, probably, I would say late 2020, early 2021. And we're hopeful that's when it would be. Once we have vaccines, it will probably be rolled out based on priority. So I see it going to people over 60 first. And then from there, branching out. We have a very robust public health network in New Hampshire, where we have over a dozen public health networks whose entire goal is to do mass vaccines. So I think we are making our and pulling out our mass vaccine plans right now, dusting them off, because it's been a long time since we've had to do a mass vaccine project. And we are working on our strategies and our systems now. So, we are getting prepared for that, for when that time comes, and we expect it to be 2020, 2021. How does this end? Oh, what a question. Even when we get new cases and deaths to zero in New Hampshire, doesn't one new infected person it all over again? Yeah, I mean, there is a degree that that I don't know that we're ever going to be zero, right? It ends when we have one of two things. We have a very viable treatment source. So we have a medicine or a therapy that when you get COVID, you can take a pill. So think about antivirals and things like that that can help treat the virus. Or we have a vaccine. That's probably how it ends, unless they find that we have long-term immunity when we get it. And then then that could change the landscape too. How does the patient get off the active case list? So active case list, person comes off after a given time frame. We maintain contact with them a couple times a week for the duration of their illness. Some people stay ill for a very long time, but we really look at 7 to 10 days without symptoms to come off the active list. Who do you recommend get tested? everybody, every single person should get tested at least once. Everybody, please go out tomorrow and get tested if you have not been tested. The governor's been tested. I've been tested twice. I'm probably due to get another test soon. Everybody in my family's been tested. You know, every single person should be tested, and you should be tested more than once. And there are so many places to get tested right now. There is no reason not to get tested. The first time I got tested at a CVS. No, the first time I got tested, I wanted to test the Pixel, which is the take-at-home test that's done by LabCorp. I paid $120 for it, I think, and it was mailed to my house. And I did my own self-swab, and it got overnighted back to LabCorp, and I had my test results in 2 days. Second time I did CVS. Probably my next time I'll go to, you know, one of our fixed sites that are up and running, but everybody should get tested. Absolutely. More than once. Go as much as you can, go as many times as you want. Go every 7 to 10 days if you want to, but everybody should get tested. Does testing hurt? The narrow swab does not hurt at all. The narrow pharyngeal swab, I heard, is slightly uncomfortable. They call it the tickle your brain swab that goes all the way back to your to the end, but it literally is seconds. Like, we have kids that do it. We have people that do it every couple weeks. So I'll call it uncomfortable for a couple of seconds. Where can we get a 1-day or a 3-day test versus LabCorp? Right now, you would access a 1-day or 3-day test if you were sick in the hospital. That's probably or if you worked in a nursing home that had an outbreak. So those 1- and 3-day tests are reserved for people that are really sick or people that are in long-term care outbreaks. We're hoping that 7 or 8 day turnaround time comes down to only 3 days. And like I said, 3 weeks ago, our turnaround time with Quest or LabCorp was only 3 days. So right now it's really high, but I don't think that you're going to access one of the quick tests just for surveillance testing. If you're symptomatic and you went to the ER, you're probably going to get a test that day, and you probably get results that day. But if you're asymptomatic, you're probably going to have to wait a little bit. Thanks for taking the time. Oh, Lisa Missler. Oh. Hi, Lisa. Oh, I lost you all. Where did you go?
Right. So I'm going to unmute Chris, because I see him still on, in case he wants to say anything to wrap us up. But thank you so much. This was very, very informative.
Well, look, all I'm going to say is I learn something new every time with the commissioner. It's great, and I just want to thank her for taking the time with all of us. It's always moving, right? So, you know, the questions that are asked today will be very different than the questions that would likely be asked a month from now. I will be in a very different situation, hopefully better, but we just don't know. Unfortunately, I say it all the time. My job is to plan for the worst and hope for the best. And the team is very good about that. It's sometimes not pleasant to do that, but I think that's how we've been able to stay ahead of it. So just being able to have the discussion, can't thank you guys enough, and just want to thank the commissioner as well.